Anatomy is what? Location, location, location. Or structure, structure, structure. How about physiology? Physiology is what? Function, function, function. Meaning that when we study anatomy and physiology, we are trying to match the function of that particular structure, the function of that particular component. All right? We are trying to understand where it is and what it does. So today we are going to understand what the spinal cord is, what it actually do. All right? So I need you to pick your pen and paper, focus on this discourse. Very important. And moreover, we'll be discussing a whole lot of questions on the spinal cord. A whole lot of questions. Questions that you meet in your usual college exams, also in the NCLEX, USMLE. We're going to touch some of those questions. We'll palpate them. All right? We will auscultate them. So pay attention. You also have to understand that thousands of people die, all right, get paralyzed just because of spinal cord injury, especially here in the US. Honestly, accidents and all whatnot. So the spinal cord is a link, all right, between the brain and the body. It's at the center of everything we do. That's why it is a component of what? The central nervous system. Remember the central nervous system as I discussed in my nervous anatomy? If you've not seen that video, please kindly pause this one, go back and see that video because I call it nervous system 1 and this is nervous system 2. All right. So the components of the nervous system, we have what? The peripheral nervous system and the central nervous system. The central nervous system, we divided it into two, which is what? The spinal cord and also the what? The brain. So last week we discussed the peripheral nervous system, we discussed the glial cells, we discussed the nervous tissues, we discussed everything that it is not, that's not what? Brain and spinal cord. So today I am discussing the brain, the spinal cord rather. Okay. The video for the brain will be coming out shortly after this. All right. So you need to pay more than usual attention. Why? Because the spinal cord is very, 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 very vulnerable to injuries. Yet it is very critical for survival. It's delicate. If you bring out a fish, all right, for both some of you that loves eating fish, all right, all these very long fish, you see the bone, long bone. That bone represents the vertebra of that fish. Trust me. If you open the bone, you will see something like looks like a cord. You know, a little milky cord, sweet. That is the spinal cord. Then if you suck that inside, you see the fluid? That is the CSF, the cerebrospinal fluid, which helps to cushion, you know, the effect of impact, of movements on the spinal cord. Without it, the spinal cord could get damaged, all right? And inflammation, that CSF can actually be inflamed. And that inflammation can lead it to different parts of the brain. The one that we are very conversant about, the pathology we are very conversant about, is meningitis, which is when that's, you know, the inflammation or the viruses and the bacteria that causes inflammation flow to the brain. Where do they flow to? Remember, the CSF flow in the arachnoid space, which is in between the arachnoid matter and also the what? The pia matter. Don't worry, relax. We are going to explore a lot of questions on this, like so many questions. So you need to pay more than usual attention. What are our objectives? The three principal functions of the spinal cord, we are going to learn that. The gross acroscopic structural organization, the neural pathways, the spinal anatomy and distribution, and the reflex arc. Why are these things important? They are very, very important because they help us in the understanding of the spinal cord anatomy, all right? And most importantly, helps us to make clinical diagnosis, sensible clinical diagnosis, all right? Because I know most of you are going to healthcare, you are going to nursing, you are going to you are going for residency, you know, physician assistants and all those things. So you need this knowledge. First, for your exams, you need to know the major functions of the spinal cord: the conduction, locomotion, neural integration, reflexes. Please, I will take questions at the end of this discourse, but you need to listen to this discourse for you to be able to understand these questions when I start pouring them out. All right? They may ask you, what of the following is not, you know, a type of a nervous function or spinal cord function rather. So conduction function, locomotion function, neural integration, and what? Reflexes. All these things are extremely important. So for location and its dimension, the spinal cord arises from the brainstem, the foramen magnum. If you bring the skull, what do you see? You see that there's a big hole beneath it. That big hole is what we call foramen magnum. That is where the spinal cord, you know, is attached, meeting the what? The brain stems, all right? It occupies the upper 2/3 of the vertebral canal and ends at the L1 vertebra, usually L1. That's why when we want to do spinal tap, we do it below L2, all right? But most people, for safe purposes, they just go to maybe L3, you know, between L3 and L4. That's safe. Why? Because usually children, their spinal cord is below L2. So when you keep growing, it keep moving up. So to be on a safe space, just go to what? Around the 3, and you'll be good to go. All right. So it gives rise to about 31 pairs of nerves. How many pairs? 31 pairs. That's one of the things they'll be testing you on. So if you look at this picture, you see the 31 pairs. These are the cervical spine. All right. This is thoracic. That's the division, subdivision rather. The cervical spine, the thoracic, the lumbar, the sacrum, and the coccygeal. You need to know how many in each. How many in each. All right. Extremely important. So that's what we have here. All right. Like, you know, it has a groove, which we divide into 2, the anterior median fissure and the posterior median sulcus. For the anterior median fissure, you have the deep and the anterior. For the posterior median sulcus, we have the shallow, which is what? The posterior. All right. So these grooves, they divide the cord into the left and the right halves. Extremely important that you know this. They divide the cord into the left and the right. I've already talked about the regional division, which is the cervical. Cervical, we have the C1 to C8. Thoracic, we have the T1 to T12. Lumbar, we have the L1 to L5. Sacral, we have the S1 to S5, and Coccygeal is just 1 pair. All right. All these things are the 31 pairs of the spinal nerves. That's what they are divided into. All right. What's the function? Why do we have to? Why is the spinal cord divided? What's the functional significance of dividing the spinal cord into segments? I want you to put the answer in the comment section below. Now, there are 3 features that you need to know about the spinal cord. 1, we have the cervical enlargement. 2, we have the lumbar enlargement. We have the conus medullary, that's medullary cone, and we have the cauda equina. These are the 4 major things that they test you on in terms of that structure of the spinal cord. If you look at this diagram, you will see all we just discussed. All right. Look at this. Below you see the lumbar enlargement. All right. The cervical enlargement is up there. It's not shown in this diagram, but we have what? The lumbar enlargement. You see this below it, you see the conus medullaris, and below it you see what? The cauda equina. We even have another one, which is the filum terminal, which is the ending this part. All right. So these are the components that you need to know about. So what are they? The cervical enlargement, right, contains neurons that supplies the upper limbs, all right, between the C5 T1. It contains the neurons. So that's something like brachial plexus came out from the cervical enlargement. Very important that you know this. Why the lumbar enlargement? They innervate the region, the pelvic region, and also the lower limb. Pelvic region, lower limb, lumbar enlargement. Upper limbs, cervical enlargement. Cervical enlargement, C5 to T1. Lumbar enlargement, T11 to L2. These very, very important. Why? Because injuries at this level are particularly severe, have particularly severe consequences for the limb. So if you have an injury around C5 to T1, you are having upper limb injury problem. If you're having an injury between T12 L2, you are having what? Lower limb and pelvic what? Challenges. Now, when you're talking about the medullary cones, that's conus medullaris. It's just that tapered end, all right, of the spinal cord. I showed you. Where is it located? Just below the lumbar enlargement. I showed you. All right. So that terminal point between L1 and L2, that is what? The conus medullaris. Extremely important that you know this. Why the cauda equina? Cauda equina is what? The tail of a horse. The tail of a horse. That's how you remember it. It's a bundle of nerve roots between L1 to L5. All right. It resembles a horse tail, and also it's usually formed during development. So these are important. They may ask you, like in my viva during medical school, they ask me about what? The cauda equina. So you need to know the cervical enlargement, the lumbar enlargement, the medullary conus, and also the cauda equina. This is where you'll be tested on. Now, you need to understand the clinical significance of the cauda equina in performing lumbar puncture, because some of you are nurses, so you will do this. Now, that brings us to the meninges. That's the coverings, the sheets covering or protecting the spinal cord. We have 3 of them. Coming from outside to inside, we call it DAP, or coming from inside to outside, we call it TAP. Pad, rather. What am I saying? So let me go from inside to outside. So the P, which is the most delicate, it makes sense because it's the most inside. It's just more like the continuation of the external part of the spinal cord. All right? Very, very tender. So this pia mater is delicate. That's the most internal. Then the middle is what? The arachnoid layer. Then after that, the outermost is what? The dura mater, which is the toughest, in case of if they ask you. It's very, very important for you to understand this. This is the diagram I wanted to show you. This is the dura, this is the arach, and this is what? The pia. So what you need to know is that between this dura mater and the arachnoid mater, you will see a space. That space, we call it what? We call it epidural space. That's where we give our epidural anesthesia. Between this dura, between this bone and the dura, epidural space. We don't have it in the brain, but we have it in the spinal cord. All right. Now, the dura and the arachnoid, they are together. They don't have a spacing between them. But After the arachnoid, between the arachnoid and the pier, there is another space which that we call what? Subarachnoid space. Of course, it's below the arachnoid, so subarachnoid space. This is the part where there contains a lot of blood vessels and also what? The CSF. That's why in meningitis, the viruses and the bacteria flow in the CSF, right? That means they are going to get to the area of what? The pier, and also to the area of what? The arachnoid matter. So that inflammation usually occurs in the pier and the arachnoid. Why? Because the CSF flows in between them. So what do you need to know from this? You need to understand what the dura is, what the arachnoid is, what the pier matter is. And you need to know the two spaces, which I mentioned, that's the epidural space and the subarachnoid space. Extremely important. Now, there is a question that they may ask, why is CSF analysis such a valuable diagnostic tool? It's very, very valuable. Let's talk about the CSF first. There are 4 major things it does. One, it's for protection. As I mentioned initially, it cushions the brain and the spinal cord from mechanical shock. 2, chemical stability. It maintains the optimal tonic environment for the neurons. Buoyancy reduces the effective weight of the brain, and also because the brain floats on it. And also, it helps to carry out what? Waste removal. Why? Because it's produced by the choroid plexus, circulated by the ependymal cells. What did I say? Produced by the choroid plexus, circulated by the what? Ependymal cells. Choroid plexus, ependymal cells. Exactly. What are ependymal cells? They are part of the what? The neuroglias, right? And we said for the neuron, the ependymal cell is what? Which type of epithelium? It's cuboidal epithelium. It produces fluid, of course. It does with fluid, so it has to be cuboidal. Make sense? So, functions of the CSF. They may ask you the location, subarachnoid space, or the central canal. Produced by what? Choroid plexus. I mentioned it. Where does it store, or where does it flow? In the brain vesicles. From the brain vesicles, it comes out through the apertures. We have 3 apertures, right? First of all, we have 4 brain vesicles. That's the 2 left ventricles, the 3rd ventricle, the 4th ventricle. The 2 left ventricle is connected by the interventricular foramen. The 3rd ventricle and the 4th ventricle, in between them, you see what? The aqueduct. Now, after that, you will see the apertures. Apertures is where they flow out. All right? To where? To the arachnoid space and to the central canal. And when they finish circulating, they go back. Where? To the blood. Through what? The arachnoid granulations. You are going to understand this in the next video, not this one. All right? So, for clinical diagnosis, lumbar puncture is very important for infections like meningitis, encephalitis, bleeding, subarachnoid hemorrhages, for example, neurological disease like multiple sclerosis, and even cancer. These are the 4 major places where we apply the role of CSF for what? For diagnosis. Extremely important that you know this. Now, when we look at the cross-section of the spinal cord, which is what you need to understand, is a little different from the cross-section of the brain. For the spinal cord, the gray matter is inside. It looks like a butterfly. It's inside. The white matter is surrounding it. For the brain, it's different. It's opposite. All right? The gray matter is outside. The white matter is what? Inside. So what's the composition and function of the gray and the white matter? The gray matter, it contains a lot of neuron cell bodies. All right? Remember we discussed about the cell body, dendrite, cell body, axon. Dendrite, cell body, axon. If you don't understand it, go back to that video. All right? So the gray matter contains more cell bodies. Why the white matter contains what? More myelinated what? Axon. That's why it's white. So the myelin sheet has a white appearance. So because this one contains more myelin sheet, it's white. Surrounded by what? Gray. What are the functions? Because this one contains cell bodies. Remember, cell bodies is where processing happens. So the gray matter is the major synaptic integration information what? Processing center of the spinal cord. Now, for the white matter, what does it do? Because it's axon. Axon helps to carry information faster. Oh, okay. It carries what? Signals between different what? CNS level. Extremely important that you know this. You need to know the function of the gray matter and the function of the white matter. You will see questions. Don't worry. You will see questions. So this is a very good diagram for you to be able to understand the entire thing. This inside is yellow, but actually it's gray. Please call it gray. Look at it. Gray. All right. It looks like a butterfly. Now, I need you to understand how to describe this. Very, very important. Okay. The formula is that anything above is what? Anterior. Anything below is what? Posterior. All right. Did I make a mistake? Yes. Anything above is posterior. Anything below is what? Anterior. Anything by the side is lateral. Very, very important. So posterior, anterior, lateral. Even the inside is medial. All right. If you know it that way, then you are good to go. Now look at this part. You see, this part is up. That is what? Posterior. This part is by the side. That is lateral. This part is down. That is what? That is anterior. Another word for anterior is ventral. Another word for posterior is what? Dorsal. So don't let them confuse you. Now, another formula you need to know is that anything white matter is either column or fasciculi, the same thing. Column and fasciculi, the same thing. Why anything gray matter is horn. Now, there are sometimes when some people are confused with funiculus. So I want you to look at this picture so that you'll be able to understand properly. This inside is known as what? Is the gray matter. You see? Is inside is the gray matter. It's yellow here, right? It's actually gray matter. Let me put on my glasses so that so you see this inside? This is gray matter. It's actually yellow here. But if you look here, this is a better view. This is gray matter. This is the histological section. All right. Now, the formula is that anything above is posterior. Anything below is what? Anterior. Another name for posterior is what? Dorsal. Another name for anterior is what? Ventral. Anything by the side is what? Lateral. Make sense? Yes. Another formula you need to know is that anything white is what? Funiculi or column. Anything white is funiculi or what? Column. Anything gray is what? Is horn. So if you know this rule, you are good to go. So look at it very well. Let's see. You see this part? This part is white matter, right? And it is up. So it was posterior column or dorsal column. You see this part? This part is by the side and it is white matter. So it's lateral what? Column. Or I can say lateral funiculi. You see this part is below, it's down. So it's what? Anterior. So this is what? Anterior or ventral column. Now look at this guy. You see this guy here? This guy is up. And this guy is what? Is gray matter. So posterior or dorsal. Look at it. Posterior or dorsal horn. This side is lateral horn. This side is what? Anterior or ventral what? Horn. You see? If you use this formula, you are good to go. As far as it's above, it is what? Posterior. As far as it's below, it is what? Anterior. Chicken. As far as it's by the side, it's lateral. Chicken. And you are good to go. Last week, we also discussed, in the prior video, we discussed that anything that goes to the brain is what? Ascending or efferent or sensory. Hence, anything that is coming down is motor or what? Or motor or efferent. All right? It's very, very important for you to understand this. Now, today we are going to discuss about tracts. Now, I need to make you understand some concept. There is a difference between column and tracts. There is a difference between funiculi and fasciculi. Some people make this mistake. Some students, they interchange it, but I will explain it to you. Columns is another name for what? Funiculi. That is white. All these things are white area. Now, column, take column as a big expressway. All right? It has different lanes. Those lanes are what? Tracts. Another name for tract is what? Fasciculi. So I can say, oh, this is a big column. All right? That's one column dividing into what? Different what? Fasciculi or different tracts. I don't know if it makes sense. So column is the same thing as funiculi. Tract is the same thing as what? Fasciculi. Tract is the same thing as what? Fasciculi. Column is the same thing as what? Funiculi. Columns are the bigger ones, and tracts, fasciculi are what? Division of what? The columns or the funiculi. Make sense? That's what the best I can explain that. Now we have the ascending, which carries sensory information up to the brain. All right. Example is touch, pressure, pain, temperature, proprioception. All these things are extremely important. And we have what? Descending. They carry motor information down from the brain to the effectors. Example is what? Voluntary or muscle control, posture balance, muscle regurgitation, regulation. Very, very important for you to understand. Why is this thing clinically important? Because tract organization allow for specific functional deficits in what? In spinal cord injuries. If you understand it properly, you'll be able to understand where is this injury going to be affected. Is there anything I can do to affect this or to support this individual? Now let's talk about the roots. But before that, let me show you the diagram. If this is the spinal cord, you see, this is the outshoots from the spinal cord. It's known as what? It's known as the root. Look at it. Roots. This is the two outshoots from this side, another outshoot from this side. So this outshoot above, I told you up is what? Posterior. Okay. So this is posterior what? Root. This one is down, anterior. Oh, this is anterior what? Root. Or I can say this is what? Another name for anterior root is what? Ventral. Another name for posterior is what? Dorsal root. Now this root joins together to form what? Spinal nerve. Then the spinal nerve now still divides into two again. Why? What into what? Ramus. Going up is the posterior ramus. Coming down is the what? Anterior ramus. It's extremely important that you understand this structure or this pathway. Now, there in the posterior root ganglion, there's one big shootout, which we call what? The posterior root ganglion. I mean, the posterior root, there is a shootout, which we call posterior root ganglion. This place is very clinically important. Why? Because when you have chickenpox, for example, and the chickenpox heals, most times the chickenpox doesn't disappear. Instead, it goes to this place and stays. This is its apartment. It lives here till when you are immunocompromised. And that leads me to asking you, what are the immunocompromised states? Okay, cancer. I know you know cancer. What else? HIV? Yes, it's an immunocompromised state. What else? I want you to give me 2 or 3 immunocompromised states in the comment section below. Don't fail to do that. So when somebody that has that is now immunocompromised, right? What happens? This chicken, the virus VZV, the virus that causes chickenpox that you had a long time ago will come down. Pew, pew. It will come down. And when it comes down, it causes what? Shingles. And you know what shingles is? Don't worry, I'll tell you that in pathology. All right, but for now, I need you to understand this and appreciate it. All right. So the roots form the nerves, then the nerve form the ramus. Extremely important that you know it. And another thing you need to understand is that the posterior root carries what? Sensory information. That means information that is going to the brain will pass what? The posterior root, all right, to the brain. But what about the ramus? Both the two roots, because they are divided from the spinal nerve, that already has the combination of the posterior and the anterior. The two ramus will have what? Both the sensory and the motor component of them. All right. But when we get to the root, the one that carries information from the brain is the anterior. That's why we call it motor. And the one that takes the information to, you see, the two green take information straight to the brain. That is what? Sensory. Make sense? Yes, I believe you understand that. So this is exactly what I just described. That's the posterior root ganglia, posterior root, and the anterior root, and the spinal nerves. I've already discussed this. Okay, now this is the divisions. You know, this is cervical, thoracic, lumbar, sacral, coccygeal. That's one pair that we discussed. So we have 8 cervical. Remember, I mentioned initially 8 cervical. But how many cervical vertebrae? 7 cervical vertebrae. But how many cervical nerves? 8. All right. Then 12 thoracic, 5 lumbar, pairs of lumbar, 5 pairs of sacral, 1 pair of coccygeal. This makes it 31 pairs. They may ask you, sacral is how many? Thoracic is how many? Remember that each of them are what? Paired. Now, when we talk about plexuses, we have cervical plexus, we have lumbar plexus, we have brachial plexus, we have sacral plexus. All right. So these plexuses are what? Complex of networks of what? Anterior rami. All the plexus come from what? The anterior rami. Do you remember what rama is or ramus is? Look at it. Look at it. You see, the spinal nerve gives rise to what? Anterior and what? Posterior. So this anterior takes care of what? All the plexuses. All right. How many of them? Forms 4 plexuses. Cervical from C1 to C5. Brachial from C5 to C1. Lumbar from L1 to L4. Sacral from L4 to S4. There are important structures that you just need to know among these ones. All right, for the brachial plexus, there are a lot that are very important. They control the upper limb. We have the axillary medial, ulnar, radial, even musculocutaneous and all those things. They are in the upper limb, all right, under the brachial plexus, C5 to T1. Now, for the cervical plexus, the most important one is what? The C3, which coordinates what? The phrenic nerves, or C3, C4, C5, which coordinates what? The phrenic nerve. And the phrenic nerve, what does it do? It innervates the diaphragm. Remember, the diaphragm is for breathing. So if you have a problem with the cervical plexus, or have a problem with your phrenic nerve, what is the problem going to be affected? Respiratory. We discussed it initially. Now, this is the lumbar L4, and the L4, it helps to provide structures or innervations to the lower limb. Femoral and obturator nerve are each major shootouts. All right, it's innervates the lower back and what? The anterior thigh. Very important that you know that. Now we have the sacral plexus. Its most important nerve is what? The sciatic nerve, which is the largest nerve in the body. All right, the sciatic nerve supplies everything down here. All right, and this sciatic nerve comes up from the spinal cord. We remember that usually the doctors always have this one, something we call sciatic nerve what? Injury. We call it what? Sciatica. Usually when the disc is touching, impinging on the sciatic nerve, makes it so sensitive, shoots out pain from up to down because that is its length downwards. Extremely important that you know this. Now we need to understand reflexes. Very, very important for you to understand reflexes. Why? Reflexes are quick, involuntary, stereotyped responses. That is what reflex means. All right. Requires stimulation. It's not spontaneous, never spontaneous, requires stimulation. For example, I do this and you blink. That's a reflex. All right. So we have reflexes that are usually quick, they are stereotyped. Anytime I do like this, you must do like this. You must blink. That's stereotyped. Stereotyped. It's quick, it's involuntary many times. Sometimes you can actually control it anyway. Now, what you need to know majorly for your exam is the reflex arc. What are the 5 components of the reflex arc? We have the receptor, we have the efferent, we have the neuron, we have the integrating center, we have the efferent neuron, and we have the effector. They are going to ask you these things, and you have to know the examples. All right. The sensory receptors, usually bone, joints, and all those things. All right. Or even the skin. These are sensory receptor. They detect stimuli. Then the nerve on this skin carries it to the brain. and it's processed in the brain. That's integrating center. And after that, the motor nerves carry it backwards to the effectors, organs, all right, glands. These are effectors. It's really important that you know this. Now, why is the reflexes important clinically? Because it helps us to understand the sensory and the motor pathway and if they are functioning properly, all right? And also the upper and the lower motor neuron lesions. Very, very important for you to understand. So when we talk about the sensory and the motor pathway, we're talking about, a lot of things, which we are going to discuss today, all right? There's something we call hyperreflexia, when that reflex is too exaggerated, which is usually common in upper motor neuron lesions, all right? Hyperreflexia. You understand? It becomes very exaggerated. Spastic paralysis, that's what usually happens there. Why the lower motor neuron lesion is usually what? Hyporeflexia. Flaccidity. You see somebody like doing like this. You can't even raise it up. You understand? That's hyporeflexia. That's lower motor neuron lesion. All right? Always remember this. Okay. Where can you test? You can test in biceps, you can test in patella, you can test Achilles. All right? Other spinal cord diseases like poliomyelitis, ALS, shingles. We've already discussed shingles. Poliomyelitis destroys the anterior horn neurons. We know about the anterior horns, right? That's one below the gray matter. Below anterior horn, gray matter. It destroys that particular area, leading to what? To paralysis without sensory loss. So if you touch them, they feel things, but they have placid paralysis, but they feel things. You understand? That place that there's paralysis, they still have sensation there. That's what paralysis without sensory loss. Also, we have the ALS, amyotrophic lateral sclerosis. It's a progressive motor neuron destruction. No cure. Once diagnosed, 2 to 5 years survival. All right? Sensation is intact. Cognition is intact. All right? So you need to understand this. So in summary, we have 31 spinal nerves. We have the gray matter, that's integrating center. We have the white matter, that's conducting center. All right. We have functions, which is the conduction, neural integration, reflex center. We also have what? We have the clinical mapping, which is dermatome. We have the reflex texting. We have injury patterns. We have diseases like polio, ALS, shingles. Always very important for you to be able to what? Integrate the entire discussion this way. All right. There are some simple questions they can ask, like why are enlargements present at cervical and lumbar vertical levels, but not in thoracic? All right. And why? Because these particular areas, which is the cervical and the lumbar levels, they contain more neurons to innervate upper and lower limbs. Extremely important. Extremely important. So I've discussed about the subarachnoid space and the lumbar puncture. Perform below the L2. I told you the spinal cord is around L1 to be safe. Go to L2, L3. We use this for diagnosing infections, hemorrhage, and other things. All right. And the CSF is found in the subarachnoid space, so that's where spinal tap happens. All right, but the epidural space is where we give AP, and it's found between the bone and also the vertebral bone and the first layer, which is the outermost layer. That is the dura. Also, spinal bifida. It happens in a lot of babies. So people that wants to get pregnant at least 3 months before your conception, you should start taking folic acid. To avoid this, because if you have folic acid deficiency, you won't even know. Many times you won't know. All right, so it's very important for you to understand this, because if you don't, it can lead to spinal bifida, which will lead to a defect in the child from the in utero. So discuss the posterior and the dorsal horns. I told you posterior receives information, lateral horns, posterior horns, they receive information. Very, very important. They are processing centers. Same thing with lateral horns. All right, they contain sympathetic neurons, extremely important. Then we have the anterior horns, all right, which sends the commands to the muscles. Then we have something we call commissures. Commissures are connections, all right, which we are going to discuss later. Now look at this simple question. What is the functional difference between the gray matter and the white matter? All right, functional difference. Gray matter, they contain cell bodies for processing and integration. White matter, they contains what? Myelinated axons for conduction between levels. Extremely important. Okay, now let's talk about the white matter and the gray matter. Properly, white matter, we already discussed that it has what? Columns. Another name for columns is what? Funiculi. Remember? Don't mistake it for tracts, which is what? Fasciculi. All right. So we have how many? 3 of them. Posterior, which I've shown you, the lateral, and what? The anterior funiculi or columns. Now, these columns are divided into tracts. They are divided into what? Tracts. So going upwards, we have what? 5 tracts. Coming back, we have what? 4 tracts. I'm going to show you. Remember, just think of the tracts as what? Expressway. So there are 5 expressway going up to the brain, and there are what? 4 coming back from the brain. Now, these tracts, there are neurons that go through it. So take those neurons as what? Vehicles. So going upwards, there are 3 vehicles. Coming backwards, there are what? 2 vehicles. All right? I'll tell you about this. Before we continue, there's something called decussation. Decussation is when the nerve fibers, they cross over to the opposite sides, right? It usually occurs in spinal tracts and results in contralateral what? Control. That's why we say, oh, right side of the brain controls the left side of the body. You know, that kind of thing. All right. So that's what we call decussation, moving opposites. All right. So opposite is contralateral. The same side is ipsilateral. All right. So this is exactly what I was talking about. You see how this nerve goes up, comes here and decussates, moves over to this side. All right. Decussates. So if something happens here right now, the thing, if there's an injury here, this particular location, it will be affecting this part of the body. All right. But if there's an injury, it will be affecting the contralateral part of the body. But if the injury affects this particular area, just, you know, below the medulla or on the medulla, it will be affecting the ipsilateral part of the body. Extremely important for you to understand this. Now, let's talk about ascending. As I mentioned, how many ways do we have? We have what? 5 ways. That's 5 tracts. How many vehicles do we have? Those vehicles are called neurons. We have what? 3 vehicles for ascending. All right. So what are the vehicles? We have the first order neuron, we have the second order neuron, and we have what? The third order neuron. The first order neuron, they direct stimulus, they transmit signal to where? The spinal cord or the brainstem. The second order neuron continues to where? The thalamus, while the third order carries the information from the sensory cortex or from the thalamus to the central cortex. If you look at this diagram, you understand what I'm talking about. This is the first order. You see, it carries the information here. It stops here. All right. This is the medulla, part of the brainstem. Remember the brainstems, the medulla oblongata, the pons, and the midbrain. So this is the medulla. The first order starts from the medulla and stops at the end from this particular place and stops at the medulla here. It gives it to the second order. The second order stops at the thalamus. Then the third order takes it to the cortex. So these are the 3 orders, 3 vehicles. All right. So let's talk about these areas where they walk. You see, these areas where they walk. How many of them? That is what we call what? Tracts. That's what we call what? Tracts. How many tracts do we have? For the ascending, we have the 5 tracts. We have the Brachial fasciculi. We have the cuneate fasciculi. Remember, now we are talking about fasciculi because we are talking about the tracts. The columns break down into what? Tracts. So we have the cuneate, we have the Brachial, that's 2. These ones are involved in fine touch, vibration, proprioception. All right. Now we have the spino-reticular tracts. Spino-reticular tracts, deep chronic pain. That means the spino-reticular tract is what carrying that pain. Spino-reticular tract. Then we have the spinothalamic tract. Thalamic, temperature, pain, temperature. Crude touch, pain, temperature. Crude touch. If they ask you about crude touch, talk about the spinothalamic. If they ask you about what? Deep pain, talk about what? The spino-reticular. And if they ask you about the touch, the fine touch, vibration, you know, proprioception, talk about the Brachial and the cuneate fasciculi. Finally, unconscious proprioception, very essential for coordination. Talk about the spinocerebellar. We have the anterior and the posterior spinocerebellar. So how many did I talk about now? 5. Cuneate, Brachial, spinothalamic, spinocerebellar, spinoreticular. So these are the 5 ways for ascending. And what are the vehicles that ascend? If you go backwards, you see the vehicle, first order, second order, and third order. So look at some of the questions that they may ask you. Why do some sensory modalities reach consciousness? Why others don't? All right. Conscious sensory pathways project to the cerebral cortex, while unconscious pathways like proprioception to the cerebellum are used for what? Automatic autonomic coordination without conscious awareness. So it's automatic. But the conscious one goes to the cortex. Make sense? So now let's talk about descending when you are coming back from Brooklyn to Staten Island. All right. We have what? The 2 vehicles. What are the vehicles? Upper motor neuron and lower motor neuron. Upper motor neuron, lower motor neuron. What are the ways? 4 ways. Any way that ends in spinal, it's actually coming down. Spine down. Spine down. So what do we have? We have the corticospinal tract. We have the reticulospinal tract. We have the tectospinal tract. And we have what? The vestibulospinal tract. 4 tracts coming back. 5 tracts when you are going. Make sense? 3 vehicles when you are going. 2 vehicles when you are coming back. What are the vehicles? Upper motor neuron when you're motor, lower motor. The 2 of them, despite the fact that it's upper and lower, they are coming down. The upper is from the cerebral cortex downwards until it terminates on the lower motor neuron. A problem with the upper motor neuron, they will ask you this question in your exam is what? Spastic paralysis. I mentioned initially. A problem in the lower motor neuron is what? Flaccid paralysis. Check it out. Simple. Now, for the corticospinal tract, is more like the opposite. It's more like the opposite of the Brachial and the cuneate. Remember, the Brachial and the cuneate, they go upwards and they are for fine touch, vibration, and for proprioception. So the corticospinal is also for precise or fine touch, fine coordination of voluntary movements. All right. We have the lateral and we have the anterior. Lateral cross about 85% of the times, and anterior cross about 15% of the times. Or cross rather. They don't cross 15% of the times. And they are called what? Anterior. Okay. Now we have the reticulospinal tracts for posture, balance, and muscle tone. All right. Then we have the tectospinal. Tectospinal. You see my head? I turn my head. I turn my head. I turn my head. Tectospinal. Turning your head. Vestibulospinal on all fours. When you bend on all fours. All right. Or when you are carrying yourself. Sometimes you see some people, they turn upside down. They are carrying themselves with their hand on the ground. That's reticulospinal. When you are standing, that is reticulospinal. When you turn your head, tectospinal. All right. For balancing and equilibrium, vestibulospinal. Very important. You need to know what all these things does. Sample questions. How do different descending tracts coordinate complex movements? This is it. Each tract has its own specialized information. All right. Which we just discussed. Corticospinal, voluntary control. Vestibulospinal, balance. Reticulospinal, posture and tone. They work together. They coordinate together. Why are sensory and motor roots separate before joining? Why do they separate? Because of organization. This helps for input and output, precise, localized lesions. All right, very, very important for you to know this. Why are there 8 cervical nerves but only 7 cervical vertebrae? Why? Because C1 is this weight above the atlas. And remember, the atlas is the first cervical bone. All right, that atlas I got to the top. Atlas I got to the top. Atlas is number 1. So that C1 is it at number 1. Then others follows the nerves. The others follows what? The cranial bone. So others that follow the cranial bones are what? 7 of them. Then the C1 is above. Make sense? Now let's talk about the branches of the spinal nerve. I told you the spinal nerve has branches. Very important that you know it. Look at this diagram. This is the posterior root. That's the dorsal root. This is the anterior root. That's ventral root. They join together. This is the ganglion here. This offshoots in the posterior. So they join together to form what? The spinal nerve. This is the spinal nerve. You see, the spinal nerve is divided into what? The up one, the down one. This guy that is connecting here. You see, these two, they join together to form what? They're communicating. And this communicating goes downwards to form what? The sympathetic trunk or ganglia. Now, I'm more interested in this one that goes upwards. This one that goes upwards is posterior, the dorsal root, the dorsal ganglia, or ramus rather. The dorsal or the posterior ramus. Then this one is what? The ventral or the anterior what? Ramus. Then this is communicating. Very important that you understand this diagram. So look at it here. What do? The posterior ramus, it innervates the deep back muscles. All right, the skin of the posterior muscles, the joints of the vertebral column is coordinated by what? The posterior ramus. Why the anterior ramus I mentioned initially for all the plexuses and also for intercostal what? Nerves. All the plexuses and also for intercostal what? Nerves. Why this is the meningeal branch, re-enters the vertebral canal, innervates the meninges. We have the meningeal branch. Then we have the communicating rami. Communicating rami forms the sympathetic what? Trunk, which I already showed you here. This is sympathetic trunk here. In this diagram, we don't see the meningeal, but you need to Google it, check it out. You will see the meninges. So this is the question: what advantages does plexus information provide over direct segmental information? Look this up. Put the answer in the comment section below. All right, or pause it. Look at the answer. I mentioned the phrenic nerve importance. I already mentioned initially. This is injury, respiratory failure. When the injury is above, remember C3, C4, C5. When it is above C4, it's what? Ventilator dependence. All right, you have to depend on the ventilator. Now, this is the brachial plexus. I already mentioned the axillary nerve, the median nerve, the radial nerve, the musculocutaneous nerve, the ulnar nerve, and these are what they do. All right. Most of the times, you have the paralysis, Erb's palsy, carpal tunnel syndrome for the median nerve if it's a problem in median nerve. All right. Ulnar nerve forms the claw. Median also forms the Benedict. Also the radial nerve palsy. All these things are problems of the brachial plexus. This is for the lumbar plexus. We have the femoral and the obturator nerve. I've already discussed it. The functions. Then this is the sciatic nerve. I've already discussed it. Sciatica, 90% from herniated disc, osteoarthritis. Sharp pain along the sciatic nerves. Extremely important that you need to know. Also, know that the sciatic nerve is L4 and S3. All right. Then we have the coccygeal. The coccygeal, the one that takes care of the pelvic floor. All right. Provides limited sensory innervation to the pelvic floor. Very important that you know this. Now, let's talk about the dermatome. There are specific skin area for one spinal nerve, specific skin area. We use this for diagnosing nerve compression and also to locate, specific spinal cord lesion. All right. So specific area for one spinal nerve in the skin is known as what? Dermatome. These are the other things about dermatome. I've already discussed the clinical importance. All right. These are other things you need to know about the dermatome, the characteristics. Each spinal nerve has its own corresponding what? Dermatome, and they are very, very well organized, extremely organized. These are different dermatomes of the body, both for upper body and lower body. But they won't be asking you specific information on dermatome in your exam. All right. Now, these are proprioceptors. They help for positioning. I mentioned initially positioning. If I tell you to stand up and you close your eyes and you are falling to different sides, then your proprioception is having some issues. So they have for positioning of the body and for movement, your sixth sense. All right. So that leads us to something we call muscle spindles. Muscle spindles, things that they don't really help you, the muscle to contract. Instead, they tell the muscle how long to contract. For example, if I'm holding this object and I want to take it, I know that I have to stretch my hand exactly to this object to take it. What tells me about the length to stretch my hand or to flex my hand is what? The muscle spindles. So they are located within the muscles. They monitor muscle length and the rate of change, and they enable coordinated posture. Imagine I want to take this thing and I put in my hand beyond it. That means my muscle spindle is affected. And what do we know as tendon organs? They are just the muscle tendons located at the junction. All right. They help to monitor tension force and to protect against what? Excessive force. So when you stretch beyond this, that's when you have what? Muscle pull or muscle injuries. Now, reflexes are divided or classified into different forms in your exam. It's classified by the effector, by complexity, by integration, and by development. In terms of development, we have innate reflexes and what? Acquired reflexes. Innate reflexes is the ones the children acquired at birth. You understand? Give a child something, they will hold, they clasp it like this. How do they know that they have to clasp it? That's reflex. How do they know that they will put it in their mouth? That's the reflex they know. That's innate. Then later they have acquired reflex, like driving the car. That's acquired. All right. Then we can define it based on integration sites. All right. We have the spinal reflexes and we have the cranial reflexes. Spinal reflexes are the ones integrated in spinal cord. The cranial reflexes are the ones integrated in the brainstem. Then in terms of effector, we have the somatic and the visceral. The somatic reflexes are the one that's connected by the skeletal muscle. I told you anything somatic is skeletal muscle, while anything visceral is what? Smooth or cardiac muscle or glands. Then in terms of complexities, we talk about how they synapse. All right. Monosynaptic, one synapse, they are very rare. Polysynaptic, there are multiple synapses. They are the most common. Make sense? So these are the 4 classifications. You must know them. And what is the mechanism of reflex, especially stretch reflex, which is my myotatic reflex? Muscle stretched, spindle is activated, spindle gives signal to the spinal cord, motor neurons is stimulated, the same muscle will what? Contract to resist stretch. All right. So the functions of stretch reflex is to maintain equilibrium, stabilize joints, smooth muscle actions. Example, we have the patellar reflex, which is the monosynaptic reflex. All right. It's a classic example. Do you see what is happening here? You see these are muscle spindles. Immediately I use this thing on your patella. What happened? Muscle spindle senses the stretch. All right. Then the information tells this guy what to do. This guy now carries the information. You see the arrow? Pumes. Sensory neuron conducts the action potential. To the brain. It's interpreted in the, I told you, interpreted in the gray matter. This gray matter interprets it, then sends information backwards. You see? Sends information backwards. See the information here. Now, there are 2 information it will send. All right? Why? Because this thing gives off another branch here. So there are 2 informations here. One is positive, one is negative. This one is contracted, this one don't do anything. All right? So number 3 is sensory neuron synapse with alpha motor neuron and interneuron. That's number 3 here. So there's interneuron, the one that's coming here, synapse here. You understand? Then after that, look at number 4. Alpha motor neuron goes to the quadriceps, stimulated. While the alpha motor neuron to the hamstring is what? Inhibited. You see? So there's inhibition of this one to the hamstring, so that the hamstring does not what? Extend. Instead, the action only goes to the one in the quadriceps. This one. So there's a plus here and there's a minus here. This is a prototype example of what? Stretch reflex. There's something we call reciprocal inhibition. The problem, when agonist contracts, antagonist must what? Relax. Simple. Otherwise, they work against each other and cancel out. That's just the nature. And what is the solution? Reciprocal what? Inhibition. So when stretch reflex activates antagonist, inhibitory interneurons simultaneously what? Inhibit antagonists, preventing what? Opposing muscle contraction. That's exactly what we, let me go back here. You see what we did here? See? This, is it purple? Yes, it's one that's sensory, comes in through the posterior. You see, I told you posterior root, sensory, came here, it breaks down. One goes to the brain. You see, look at it. Then the brain interprets and tells the guy at front, which is the quadriceps, it tells it to what? Contract. And the one behind, which is the, this one behind, look at this one behind. You see, that's the hamstring. The hamstring, it tells it to relax. That's exactly what reciprocal inhibition is about. All right. Patellar reflex, quadriceps stimulated, hamstring inhibited, smooth muscle movement. Simple. Then we have the flexor reflex. That's withdrawal reflex. I touch hot pot, I withdraw my hand. You see, stimulus, painful, usually painful stimulus, stepping on a glass or touching a hot object. Response is what? Rapid flexor withdrawal. Characteristics: polysynaptic, ipsilateral, protective. Polysynaptic means what? Multiple interneurons. Ipsilateral, it means it's always in the same side of the response. All right. Protective is it removes body parts from hand. So I touch hot object, I remove my hand. Right hand removes right hand. I don't touch hot object and what? My left hand is what is removed. No. That's what we call what? Ipsilateral or same side what response. And it's polysynaptic. So look at what happens here. You see, you step on a needle or something, you contract or flex. This is what? Ipsilateral, same side. You see, this is information telling this guy to contract here. Why? There is an opposite inhibition. Look at it. In the other leg, opposite inhibition in the other leg. All right, that's extension. We call it what? Cross extension what? Reflex. This place becomes contracted. You flex here, you extend in the other leg automatically. That's what we call what? Cross extension reflex. So the problem, flexor reflex withdraws one limb, would cause loss of balance. So once it causes loss of balance, what is the solution? Cross extension reflex. The other area we have to stiffen up, to contract. The extensor muscles will contract, providing what? Support for your leg, because now you are standing on one leg. It's just like raising one leg up. You're standing on one leg. So step on a nail with the right foot. Right leg flexes, that's withdrawal. Left leg extends. You have to maintain what? Balance. This is what they will ask you. So you need to understand this pattern. All right. Then we have Golgi tendon organs. These ones are proprioceptors, mechanism, excessive tension. Tendon organ what? Gets activated and inhibits what? Muscle contraction. When there is two extension, maybe I stretch my hand like this, I continue stretching it. Automatically, my tendon organs will get activated and inhibits that muscle contraction. All right. If not, the tendon will tear, cause muscle injury. All right. So peripheral nerve injuries, we have the radial nerve palsy. That's what we call Saturday night palsy. Or you can have a compression that we call wrist drop, cross paralysis. You cannot extend the fingers. All right. Then we have median nerve carpal tunnel syndrome. So anytime you see median nerve, remember carpal tunnel what? Syndrome, or even Benedict's hands, which is numbness in lateral what? Fingers. That's Benedict. Then we have the sciatic nerve injury, causes sciatica. All right. 90% as a result of herniated disc. You need to know this for your pathology. All right. Then these are different, paralysis. We have the quadriplegia, paralysis on all four limbs. We have the paraplegia, paralysis on both what? Lower limbs. And we have the hemiplegia, paralysis on one side. We also have the paresis, which is what? Partial paralysis. Which of the following is not a function associated with the spinal cord? Let me give you option. Protects neurons in both the ascending and the descending tracts. Mediate a reflex such as withdrawal of a hand from pain, conduct sensory information up to the brain, conduct motor information down the cord, coordinate the alternating contraction of several muscle groups associated with locomotion. I need you to put the answer in the comment section below. Yeah, the answer is to protect neurons in both the ascending and the descending tracts. Protection. Remember other functions associated with the spinal cord? We talk about the conduction, locomotion, neural integration, and reflexes. Protection is part of it. Bear this in mind. Sometimes they may ask you, which one is not considered a region of the spinal cord? Do you remember the regions of the spinal cord? Think about it. Do you? Let me get this is the regions of the spinal cord. They give you options like cervical, thoracic, lumbar, pelvic, sacral. You automatically know it's what? It's pelvic. So these are the things. That's why I did this slide for you to be able to understand. So if you look at this slide very well, you get all the questions they will definitely ask you. Imagine a question asking you, the middle layer of the meninges is called the dash. What is the middle layer? I'm not giving you option. Look at this particular slide and put the answer in the comment section below. Now they ask you a question about the horn, or rather the cerebrospinal fluid. And they ask you, cerebrospinal fluid fills the space between where and where? Fills the space between where and where? What did I tell you? Cerebrospinal fluid is found where? In the subarachnoid space. And the subarachnoid space is between where and where? The arachnoid matter and what's the pear matter. So you see, anything they can ask you is in the slide, in the discourse already. Now they can ask you, the bundle of the nerve roots that occupy the vertebral canal from L2 to S2, rather from L2 to S5, is called the dash. And remember what I told you. What are the areas you need to know? Cervical enlargement, C5 to T1. Lumbar enlargement, T12 to L2. Then I go to this page. Medullary cone, L1 to L2. Caudal equina, L2 to S5. Oh, it's caudal equina. And what are the options? They will give you all these things in the option. The medullary cone, A. Caudal equina, B. Lumbosacral enlargement, C. Cervical enlargement, D. Spinal cord, E. The answer is what? As far as they say L2 to S5, the answer is caudal equina. You need to know these four, at least, because they're very specific. And look at this question they asked. Which of the following structures would be the least likely to cause a spinal cord injury? Think about it. Where can the spinal cord injury be caused? If you look at the introduction I gave here, I told you that there are 31 pairs of spinal nerves, right? And all of them arises from, the spinal cord arises from the brainstem, the foramen magnum, right? From the brainstem to where it ends at the L1 vertebra. Meaning that anything below L2, right? Or let me say below L3 is safe. So if you have an injury at L3, somebody had an accident, has injury at L3, will the spinal cord be affected? No. That's what they are just asking. So look at the question again. Which of the following fractures would be least likely to cause a spinal cord injury? They say a fracture of the cervical vertebra C2. C2 is, you know, where spinal nerve, cervical nerve 3 comes out from. A fracture of vertebra C6. That's where C7 comes from, right? A fracture of vertebra T5. A fracture of vertebra T12. Now they said a fracture of vertebra L4. Oh, that has to be the answer. Why? Because the spinal cord ends at what? L1 vertebra for adults. In children, probably around below L2. So if they say L4, that is safe. If somebody have an accident in L4, the person will be fine. No spinal cord injury. Now they say epidural anesthesia is introduced to the epidural space between the dash to block pain signals during pregnancy. So where is the epidural space? Do you remember this diagram when I told you that the between this bone, for the spinal cord rather, between this bone and the dura, you find what? The space. That space is called epi, outside. Dura, outside the dura. So above the dura, we have epidural what? Space. That's where we give anesthesia. So they're telling you epidural anesthesia is introduced to the epidural space between you. If you know it, you know the answer. Options, they say dura sheath and dura mater, dura sheath and vertebral bones, dura mater and arachnoid mater, dura arachnoid mater and pia mater, dura mater and pia mater. No, the answer is what? Dura sheath and what? Vertebral bones. So this is the vertebral bone and this is the dura sheath. If they are talking about the where you get the spinal tap from, you are talking about what? The arach and what? The pia. This green and this one inside. Now, look at this question. Which of the following is contained within the gray matter? Which one? See? Gray matter, white matter composition of gray matter, composition of white matter. What do we say is in gray matter? Neuron, cell bodies, myelin sheets, you know, and it looks like a butterfly. Cell bodies, myelin sheets, butterfly. Then after that, you can now start getting dendrites and some part of the what? Axons. But the one that has the major axons, myelin sheet, myelinated axons is what? The white matter. That's why it's white. So look at the question. Which of the following is contained within the gray matter? They have glial cells, axons of motor neurons, and Schwann cells. True? Nah. They have glial cells, myelinated fiber. That's white. All right? That's white matter. Then see, they have cell bodies, dendrites, and proximal parts of axons of neurons. That is the answer. That has to be the answer. Then the fourth one, the distal parts of axons of lower order motor neurons, dendrites, and proximal parts of the axons. And another question that we ask you is about synapses of the upper motor neuron and the lower motor neuron. So they say many upper motor neuron synapses with lower motor neurons in the answer is anterior horn. They will tell you posterior horn, posterior funiculus, anterior fasciculus, blah, blah, blah. The answer is what? Anterior horn. The answer is what? Anterior horn. Now, look at this question that says, motor commands are carried by dash from the brain along the spinal cord. Motor neuron commands are carried by what? So they are comparing ascending and descending tracts. What is ascending tracts? Carries sensory information up, right, to the brain. What is descending tracts? Carries motor information what? Down. So the question is, the motor information are carried by dash from the brain to the, so it's coming down from the brain to the spinal cord. So the answer has to be what? Descending tracts. Now they're asking you about the motors that's coming from that are going to the to Brooklyn. All right, that's the ascending ones. They say second order neurons synapse with third order neurons. In the what is the answer? In the what is the answer? The options: thalamus, dorsal root ganglia, spinal cord, cerebral cortex, medulla oblongata. Looking at this diagram, what do you see? This is the first order. It remains in the medulla, right? Second order. Stops at the thalamus. So the answer is thalamus. Check it out. So second order terminates at and continues at third order in the what? In the thalamus. Remember, we discussed about going up. We said 3 vehicles going up. That's first order, second order, and third order. And how many tracts are they going up with? 5 tracts. All right. Now look at this question on tracts. Which of the following is an ascending tract of the spinal cord? What are the ascending tracts, guys? Brachial, cuneate, spinothalamic, spinothalamic, and what? Spinocerebellar. Now look at this question. The option says lateral tectospinal, medial reticulospinal, ventral corticospinal, and vestibulospinal, and gracial fasciculus. The answer is what? Gracial fasciculus. That's why you need to know these things. I told you anything that is spinal is coming down. Anything that is spinal is coming back from Brooklyn to Staten Island. It's coming backwards. All right, that's descending. That's motor, right? So tectospinal is motor, reticulospinal is motor, corticospinal is motor, vestibulospinal is what? Motor. Now coming back, we said there are 4 ways, right? We have the corticospinal tract, we have the reticulospinal tract, we have the tectospinal tract, we have the vestibulospinal tract. Now this is the question. The signals that control your handwriting travel down the spinal cord in the dash tract. It controls your handwriting. That handwriting is what? Fine, precise, coordinated, voluntary movement. So what should it be? Corticospinal. That's why you need to know the functions of these ones particularly. All right. And they ask you about nerve fibers. I discussed it in the that's why I didn't discuss it in this particular video, because I discussed it in the first video. So please go and watch that video. All these things are continuation. Nerve fibers are insulated from one another by what? So what they're asking you, what wraps each nerve fiber? That's endoneuron, right? Endoneuron. The perineuron wraps up fascicles. What are fascicles? Group of what? Nerve fibers or nerve cells. While the epineuron wraps up the entire muscle tendon. All right. And there's a question about eyes and ears. What innervates your eyes and ears? That's very special muscle fibers. Very special muscle fibers. They will ask you that. So now they may ask you about ganglion. What is ganglion? Options: bundle of axons in the CNS, cluster of dendrites in either the CNS or the PNS, cluster of cell bodies in the PNS, bundle of axons in the PNS, cluster of cell bodies in the CNS. Please, the answer is cluster of cell bodies in the PNS, peripheral nervous system. It's in the peripheral nervous system. Example, this is posterior root ganglion. What did I say happens here? This is clinically important because what? VZV comes here to hide until you are immunocompromised before forming shingles. Extremely important that you know that. That's why sometimes it can form a cyst, like the one that usually happens in this area. You see one swelling here. Call it what? Ganglion cyst. Which of the following branches of a spinal nerve has the cell bodies of only sensory neurons? Only sensory neurons. Look at the spinal nerve. All right. Only sensory. So let me assume this posterior ramus is a branch, this anterior ramus is a branch. Are they only sensory? Because they will ask you this question. The options you will see: posterior dorsal root, anterior ventral root, posterior ramus, anterior ramus, Meninges branch. Please look at it properly. This is the anterior ramus. Does it have only sensory? No. The green is the sensory, the red is the motor. So the anterior ramus has both. The posterior ramus has both. All right. Spinal nerve has both. But look here, you see, this posterior area has only what? Sensory. Look at it here. So information going to the brain only goes through this particular route, but not this route. This route has only motor. So when they ask you which branches of the spinal nerve has the cell bodies of only sensory, they are talking about what? The posterior root. So the answer has to be posterior root or dorsal root. And also they can ask you cell bodies of the anterior roots are located where? They are located where? The gray matter. Look at it now. See how it enters the gray matter? See how it enters the gray matter? It has no business with these guys here. Instead, it enters straight to the gray matter to process that information. Now, a mixed nerve consists of both dash and dash. Mixed nerve. Mixed nerve. Look at it. This is a spinal nerve. All right. You see this and this. So a mixed nerve. Why? When they say it's mixed, you see it has both what? Sensory and what? Motor. So it has both efferent and what? Efferent fibers. It's as simple as that. So mixed nerve consists of what? Both efferent and what? Efferent fibers. A and E. And you will know that a nerve is a cord-like organ, right? It's composed of numerous what? Axons. I already discussed it in the first video. That's also a question that they may ask you. Now, they ask a question, sensory stimuli enter the spinal cord via what? All of us know it's the afferents. It's as simple as that. They may tell you sensory receptors, efferent effectors, efferent axons, interneurons, efferent axons. Please, it's axons, so it's what? Sensory axons or efferent axons. Don't let them deceive you with sensory receptors. No, receptors is just a sense. Then the nerve carries it from receptors and go up. Now, look at this question. Which of the following is comprised of anterior rami from C5 to T1? First of all, what do we know about the rami? We said that the rami, right, anterior rami is the one that takes care of all the plexuses, all right? These plexuses, the sacral, the cervical, the brachial, the lumbar, is from the what? Network of anterior rami. That is the question. Then another question is saying, which of the following is comprised of anterior rami from C5 to T1? This one, you don't even need to think it. Cervical plexus is C1 to C5. Brachial is C5 to T1. Lumbar is L1 to L4. Sacral is what? L4 to S4. You need to know these things, all right? And know the prominent examples. So, they ask you which one, C5 to T1 is what? Brachial plexus. Brachial plexus. Okay. Now, another question they can ask you is the anterior rami of the spinal nerves form plexuses, nerve plexuses in all regions except the dash region. This one is very straightforward. We have the cervical, we have the lumbar, we have the brachial, we have the sacral. So it doesn't form in the thoracic. It's as simple as that. You pick your answer and you go your way. Now they can be specific. What is cervical plexus is the origin of the dash nerve. They want to know which nerve specifically. They said sciatic nerve. Sciatic nerve is the sacral. They tell you musculocutaneous, radial nerve. That is the brachial. All right. They tell you obturator nerve. That is the lumbar. Then they tell you phrenic. Phrenic, cervical. So if you know phrenic for cervical, obturator, femoral for lumbar, sciatic for sacral, and all these guys for brachial, you are good to go. They may ask you which of the following nerves originates in the lumbosacral plexus. They're talking about the sacral plexus, and that is the sciatic nerve. You go, the largest nerve. All right. Now they may ask you what is the property or which of the following is not a property of reflexes. Simple. I already pointed out the properties, so you need to know the properties so that you'll be able to pick out which one is not when you see a question like that. Now, they will ask you this question. Which following best describes the order of a somatic reflex? This is the order, all right? From the somatic receptor to what? The efferent nerve fiber, to the interneuron, the efferent neuron, and the what? Effector. Chicken. So if they're asking you how many spinal reflexes does a simple neuron, a simple reflex have, that's three. It's as simple as that. This 1, 2, and 3. When a nurse pricks your finger to take your blood type or to check your blood type, the flinch, the pain, pulling your hand backwards. What is it called? Painful stretch, flexor, or withdrawal reflex, tendon, cross extension. You see, when you step on stimulus or when they prick your finger, that is what? Flexor reflex. They can tell you it is withdrawal reflex. Yes. Now you need to also know about the fibers. I mentioned this during the discourse that the fibers that carry action potential that cause skeletal muscle to contract is what? Alpha. For contraction is alpha. What about the ones that coordinate the muscle spindles? That is gamma. Alpha is the one that helps for contraction. Gamma is the one that controls the motor spindles. All right? Muscle spindles. And I tell you, muscle spindle is not involved in contraction. Instead, it helps you to, it gives the muscle the length. When I was describing, touching something. And you need to know what contralateral is, what ipsilateral is. Very important for you to know. Tendon reflex, tendon organs, always what? Proprioceptors. Look at it. Golgi tendon organs are usually what? Proprioceptors. And also remember the classification of reflexes, because they say a reflex that's only used 2 neurons are called dash reflex. It's a monosynaptic. It's a monosynaptic, not a polysynaptic. 2 neurons, that's just the only synapse in one place. See, it's monosynaptic. Okay, so finally, I'll give you this question. I want you to go and put the answer in the comment section. I'll give you a few questions to put in the comment section for me, but I want you to write the question, then put the answer. All right, let me know if it's correct or not. Muscle spindles of the hand, all right? Muscle of the back, muscles of the thigh, muscles of the middle ear, muscles of the torso. Which of the following groups of muscles has the most muscle spindles? Among the options I just gave you, which one has the most muscle spindles? Also, this question, you go to the movies, after a long day, you begin to nod off. As soon as the movie starts, your head starts to lower, to lower a little. The reflex causes your head to rise. This is called dash reflex. You're in the movie. I want you to put the answer for me in the comment section. The options are tendon reflex, cross extension reflex, withdrawal reflex, stretch or myotatic reflex, flexor or withdrawal reflex. Put the answer in the comment section. I just want you to write sleeping at the movie. If I take you to movie and you sleep, you have to give me my money back. It's important that you know this, all right? So these many others, you know. So I want you to join my free live session this weekend. If you've seen this video, this weekend on Sunday by 7 p.m., I'll be doing free live session so that you'll be able to know a lot of things about anatomy. We'll also review some of these questions and many more, all right? Most importantly, like this video, make comments, please. Like, make comments, put on your notification bell. If you've not subscribed, subscribe. This will help you to get much more information as the day comes by. And remember, this is a recap for your anatomy exams, college anatomy exams, for the NCLEX, USMLE, and any medical exam that you're writing. This is extremely important to you because these are some of the questions they're asking, no matter the country where you are, no matter the school where you are. Very, very important for you. Please send this video to your friends and colleagues. And thank you so much for being with me. I'll see you later. Ciao.